Zebronics for life.
And we will be there to the last. So we start in 3, 2, 1. Please go.
Zebronics for life.
Bluetooth mode.
Welcome to this live webinar.
Now connected.
I am Sumit Kumar Madan from Zydus Life Sciences Limited, and on behalf of Zydus, I welcome our guest speaker, Dr. Paula Bolton-Max from University of Manchester, United Kingdom, our chief guest for the day, Dr. Vijay Tilak, all discussants and participants to this virtual symposium on prevention and treatment of infections in the absence of spleen. Before we commence the proceedings, I would like to welcome and introduce the host and convener for this webinar under the aegis of Mumbai Hematology Group, Dr. Amit Khurana. Dr. Amit Khurana is a senior hematologist and bone marrow transplant physician from Surat in Gujarat. Dr. Amit has been a keynote speaker at various national congresses and conferences. I request Dr. Amit Khurana to navigate this program further. Sir, over to you.
Thank you, Mr. Sumit. Well, very good morning to all of you, and good afternoon and good evening to all of those who are joining from rest part of the world. Today, our guest speaker for the day is Dr. Paula Bolton-Max from Manchester, UK, and she's going to lecture us on prevention and treatment of infections in the absence of spleen. This webinar is brought to you by Mumbai Hematology Group, supported by Zydus Dedicated to Life, and managed by Perfect Square. I thank Mr. Ashish Kumar, Mr. Sumit Madan and team Zydus, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Professor Dr. Vijay Tilak from Varanasi, our guest speaker for the day, Dr. Paula Bolton-Max from Manchester, UK, and all our discussants who are themselves very eminent hematologists as well as hemato-oncologists, and you participants for sparing your Sunday morning, afternoon or evening from whichever part of the world you have logged in. Let me give a flavor of our next weekend activities. Next Saturday, that is 11th of January 2025 from 7 p.m. Indian Standard Time and 8:30 a.m. US Eastern Time, we have Dr. Talha Badr from Florida speaking to us on risk stratification and management of lower risk MDS. And the following date, it is 12th of January 2025, we have again Professor Dr. Wojciech Jurzak from Poland speaking to us on refractory R large B-cell lymphoma after ASH 2025 from 11:30 a.m. Indian Standard Time and 7 a.m. Polish time. Let me introduce our discussions for the day, and they are here displayed in alphabetical order. To start with, we have Dr. Amrit Kaur Keller from Kokilaben Dhirubhai Ambani Hospital, Mumbai, Dr. Aditya Jandial from Homi Baba Cancer Hospital, Mulanpur, Punjab, Dr. Akanksha Garg from Zydus Hospitals, Ahmedabad, Dr. Ankit Rayani from Cure Hematology Oncology Clinic, Ahmedabad, Dr. Ankur Ahuja from AFMC Pune, Dr. Bharat J. Parikh from HOC Vedanta, Ahmedabad, Dr. Chirag Shah from Apollo Hospitals International, Ahmedabad, Dr. Deep Gala from SGPGI, Lucknow, Dr. Dinesh Burani from Rajiv Gandhi Cancer Institute and Research Center, New Delhi, Dr. Fahima Hassan from United Institute of Medical Sciences, Prayagraj, Dr. Kripa Bajaj from KIMS Hospital, Hyderabad, Dr. Kunal Goyal from Kokilaben Dhirubhai Ambani Hospital, Navi Mumbai, Dr. Lisa Bulsara from Avinash Cancer Clinic, Pune, Dr. Manoj Uni from Amrita Institute of Medical Sciences, Kochi, Dr. Mohammad Rifai from Government Medical College, Calicut, Dr. Nitin Gupta from Sir Gangaram Hospital, Delhi, Colonel Dr. P. Suresh from RNR Army Hospital, Delhi, Dr. Prashanta Bhatt from KMC Hospital, Mangaluru, Dr. Pritesh Junagade from Lotus Institute of Hematology, Nashik, Dr. Rajan Yadav from GCRA, Ahmedabad, Dr. Rizwan Akhtar from SGPJ, Lucknow, Dr. Satish Kumar A from Manipal Hospital, Bengaluru, Dr. Sitharam Anandram from St. John's Medical College Hospital, Bengaluru, Dr. Siddesh Kalantari from Blood Care Hematology Clinic, Nashik, Dr. Sudarshan Pandit from Blood Plus Hematology Center, Nashik, and Dr. Tejaswini Gudibande from Max Super Specialty Hospital, Durgigudi, Shimoga, Karnataka. Now it's time to introduce our special guest and the chief guest for the day. We have with us Professor Dr. Vijay Tilak from Varanasi. Professor Dr. Vijay Tilak is the organizing chairman of 66th Annual Conference of Indian Society of Hematology and Blood Transfusion, that is Hematocon 2025. He is the founder president of Uttar Pradesh Hematology Group. He is also the founder president of Kashi Hematology Group. He is a joint secretary of Indian Society of Hematology and Blood Transfusion, ISHBT. He was designated fellow of ISHBT in the year 2018 and fellow of Indian College of Hematology, ICH, in 2023 for outstanding contribution to the field of hematology and the cause of society. He is the editor-in-chief of Hematology Indica, the official newsletter of ISHBT. He is a former head, Department of Pathology at Institute of Medical Sciences, Banaras Hindu University, Varanasi. He is also the editor-in-chief for 4 books in hematology, published 62 papers, organized 24 academic meets in the past 8 years, including 5 national hematology conferences. He is presently the professor, Department of Pathology, Institute of Medical Sciences at Banaras Hindu University, Varanasi. It's my privilege to inaugurate It's my privilege to welcome Professor Dr. Vijay Tilak to inaugurate our webinar and give some words of wisdom. Over to you, Professor Dr. Vijay Tilak.
A very good morning to all of you. Hematology is at a very exciting phase of its growth, both on the clinical side as well as on the laboratory side. On the clinical side, targeted therapies and personalized medicine have resulted in a significant reduction in the mortality and morbidity. And on the laboratory side, newer and more precise diagnostic tools have enabled the hematopathologist to reach a faster and much more accurate diagnosis, and this is translating into much better outcomes. Friends, therefore, all those of you who are interested to pursue a career in hematology can look forward to a very exciting times, and with artificial intelligence knocking at the doors, the future of hematology is very bright. But all this entails dedicating yourself to a lifetime process of learning. The good news is that we have numerous platforms that are available where we can continuously update our knowledge. For instance, DM programs, fellowships, conferences, pre-conference workshops, CMEs, and then COVID pandemic has boosted the online platform in a very big way, and we can utilize these platforms for continuously updating our knowledge. So while you are pursuing a career in hematology, I would request all of you to be mindful of your health. Take care of your good health, because investment in good health is one of the biggest asset, and it pays rich dividends throughout your life. And last but not the least, you need to give time to yourself and to your loved ones. take a break from the mundane to rejuvenate, revitalize, and return back to your workplace, and that will definitely enhance your productivity. So, in a nutshell, dedicating yourself to lifetime learning, uh, then update, being a part of this, be mindful of your health, and uh, dedicating your time to to yourself and to your loved ones will ensure that you have a very bright future in hematology. I wish you all the best. Thank you very much.
Thank you, Professor Dr. Vijay Tilak. I think you've given a wonderful message, and the two important messages which you brought out. One is learning, one is skills, education, practice, but above all, family time is very important, and time to be given to the loved ones also. Thank you so much for joining us as our chief guest for the day. And now let me share the screen again. Let me introduce our guest speaker for the day. We have with us Dr. Paula Bolton Max from Manchester, UK. Dr. Paula Bolton Max is DM, FRCP, FRC Path, Honorary Senior Lecturer in Hematology at Faculty of Biology, Medicine and Health at University of Manchester, UK. Dr. Paula is trained at both Cambridge and Oxford universities and has been a consultant hematologist since 1991, initially as a pediatric hematologist at Alder Hey Children's Hospital in Liverpool, and then as a consultant in adult hemostasis and thrombosis at Manchester Royal Infirmary. From 2011 to 2018, she was also medical director of the UK National Hemovigilance Scheme, focusing on serious hazards of transfusion, that is SHORT, www.shortuk.org. Her main research areas focuses on factor 11 deficiency. She has a long-standing interest in both hemostasis and transfusion and has contributed to several British Society for Hematology guidelines, including those for prevention of infection in people with absent or hypofunctional spleens, guidelines for pediatric transfusion, as well as appropriate use of FFP and cryoprecipitate. She has published 185 peer-reviewed papers and guidelines. She remains actively involved with SHORT and other areas of hematology and transfusion medicine. And today she is with us, and she's going to lecture us on a very important topic, that is prevention and treatment of infections in the absence of spleen. Well, thank you so much. I stop over here. Over to you, ma'am.
Thank you very much indeed. I'm just going to share my screen. You should be able to see my presentation.
Yes, ma'am. Please go ahead. Can you put on the full screen mode?
Yeah, oops, I can't. I've lost it. Just a minute. I had it just now. No, I can't see it. Bear with me, please.
There'll be a small symbol on the lower right side for the full screen mode presentation.
I can't even see it at the moment.
Hi, ma'am. This is Nikhil. Can you go to the view on the top right?
I can't see where to do it. View option.
There is a view button on the top in the middle of the page. There is a home button, insert, draw, design, transition on the top.
No, I've got. Can't see it. I've done something stupid.
Ma'am, can you see home on the top
No.
top left?
No, I can't.
Okay.
Sorry, I had it working perfectly well yesterday. I did a trial run.
Can you switch off the slideshow and switch on again?
Can you see me now? Can you see it now?
No. I can see the view. Yes, slideshow.
I can't see the button to play it. That's the trouble.
You just switch off switch off the slideshow and switch on again. Close the file and open the file again.
Please stop share. You need to stop sharing and
Yeah,
then
and stop share.
stop share. And then again, you may try.
Yes, there is a.
I can't see the icon to make it play.
Okay.
Usually it's at the bottom of the screen, but I can't see it today. I've got it now, don't worry, it's here. That should work. Does that work for you?
Yes, perfect.
Perfect. So sorry about that. So you already know what the topic is we're going to discuss, so I'll immediately proceed with the next slide. And this is based on a recent update to our guidelines for the prevention and treatment of infection in patients with an absent or hypofunctional spleen. And these are the authors, and it's quite important to list them because I'm just part of the writing committee. I'm a hematologist, as you know, but the principal trigger for this guideline was from Shamiz Ladani, who's professor of pediatric infectious diseases in London. And he recognized that the guidelines that we had produced in the past, why won't it run? Yes, in 1996, 2002 and 2011 were now out of date because of developments in vaccination policy and the vaccines that are available. And so we decided to revise it. Savio Fernandez and Matt Tagarg are both general hematologists, and Ray Burrow works in the meningococcal lab in Manchester, so he's an expert on that. Simon de Lusignan is a professor of general practice working in Oxford, who is very helpful in helping us to look at further implications, because the prevention and treatment of infection in patients with an absent spleen involves a lot of different people. So the plan for my talk will be to look at the role of the spleen and the consequences when it's not working or absent, to consider who's at risk and how you make the diagnosis, to think about education and maybe the role of national registries, then to look at vaccination schedules, and finally to consider who should have antibiotic prophylaxis. So what is the role of the spleen? I'm sure I don't need to tell this eminent audience this, but I thought it would be useful to remind us. First of all, the spleen removes old and damaged red cells by culling. It also removes particles from cytoplasm with pitting, and that's quite useful in diagnosis. But most importantly, perhaps, it removes opsonized microorganisms, particularly encapsulated bacteria, and we'll come back to that, but also other organisms such as malaria. It also is a source of production of IgM antibodies. So what are the consequences of an absent or dysfunctional spleen? Well, first of all, the risk of overwhelming infection, particularly with pneumococcal species, OPSI, overwhelming sepsis, which can be lethal in a matter of hours. And then the patient is vulnerable to infection with other encapsulated organisms, particularly meningococcal species and Haemophilus group B, but also, as hinted before, infection with malaria, capnocytophaga species, which you can receive from dog bites, and other organisms, babesiosis and Anaplasma phagocytophilum, which are both organisms that you can acquire from tick bites. So the spleen is a pretty important organism to prevent infection of all sorts. But the other thing that may not be so well known is that there is a long-term thrombosis risk, including pulmonary hypertension, after splenectomy, so both short and long-term, which we might like to think about. What is the evidence for thrombosis after splenectomy? Well, there are three areas where we can think of evidence, and for me, the most convincing really was the work by Robert Schilling, which is the first bar that you can see here, where he did a very large study of United States families with hereditary spherocytosis, 574 people. Some of those people will have had their spleens removed and some won't. And he looked at the hazard ratio for arterial vents in people who'd had splenectomy versus not splenectomized and found a hazard ratio of 7. And for venous events, the hazard ratio was also increased at 3. Then we know that individuals with persistent hemolysis and abnormal red cell morphology after splenectomy have a definite risk. That's people with thalassemia intermediate particularly and stomatocytosis. And then he also analysed in his data a risk of pulmonary hypertension in patients who'd had splenectomy for trauma. And he's written a very interesting paper in the British Journal of Haematology some years ago, balancing the risks and benefits of splenectomy, which is important to us in the UK when we're considering whether or not somebody should have a splenectomy who has hereditary spherocytosis. But I recognise that's probably not your main area of interest. This bar is annoying. Let me move it up. So the key points. Sorry. Screen sharing, I've lost it again. What did I do? I've lost my screen share. Why does it do this?
So we are able to see your screen, ma'am.
Oh, well, I can't see it, so that's much good.
Okay, you can unshare once again. And then
I was trying to get rid of the bar of very irritating things at the top of my screen. Okay, stop share.
Once again, you can reshare.
Yeah, there we go. I'll stop fiddling with the stuff at the top. So the key points really about this is first of all, identification of the people at risk. Then secondly, and very importantly, education of the patient, their family, relations and medical staff, nursing staff, laboratory staff, but particularly the doctors looking after the patients. And then we're going to consider the vaccination schedules and antibiotic prophylaxis. So who is at risk? And the problem is that there are so many different areas in medicine where people can have either a hypofunctional spleen or an absent spleen across many different medical specialties and patient ages. And this makes it quite difficult to pull all these individuals together under one umbrella. So first of all, as you see here, we could have people who are born without a spleen, congenital splenetic absence. But then there's a whole tranche of different reasons: emergently splenectomy after trauma, all sorts of hematological and neoplastic diseases, the sickle cell disorders and thalassemia, which I guess is a major area for hematologists in India. Then you can have a dysfunctional spleen in a lot of different autoimmune diseases, and we can look at those in a bit more detail a bit later if you like. And then there are a whole raft of patients with liver disease or gastrointestinal disease who can also have splenic hypofunction. So how do we draw all these, how do we find all these patients and how do we educate them? Let's consider diagnosis. Well, if you're not sure whether a patient's got an absent spleen or not, the presence of Powell Jolly bodies on the peripheral blood smear is a simple way of finding out and quite easy to do. But how reliable is it? Well, it's reliable. If you find them, then the patient has a spleen that isn't working properly. But you can also look for pitted erythrocytes by phase contrast microscopy. And I don't know whether these are quite clear. There's a pit there and one there. But this is quite a difficult technique to do. It's not easy to have it available in the lab. And then there are two other techniques: spleen scintigraphy with labeled red cells, or flow cytometry for IgM positive, CD27 positive B cells. But again, that's not a routine finding. So what's of particular interest is this paper that was published in the British Journal of Haematology in December, which was a nice description of a novel test of splenic function, which could be applied, I think, in a lot of clinical diagnostic laboratories. What did they do? They recognized that high mannose glycans are extracellular misfolded glycoproteins, which you don't usually find on red cells because they're filtered out by the spleen. So if the spleen isn't working, these are not filtered out, and analysis by flow cytometry can show you that they're there. So here's a picture of the flow cytometry of asplenic people having their peak in quite a different position than the normal individuals. So they took blood samples from 527 individuals, of which 192 were standard normals, if you like, hemoglobin AA, and then non-AA, 335, which included 197 with sickle cell disease, other hemoglobinopathy variants, post-stem cell transplant, and 5 who'd had a splenectomy. And here are the results that they show. Here's the Galanthus nivalis leptin complexed with this substance to make the peaks visible. And the increased fluorescence is associated with splenic dysfunction, and it correlates very nicely with pit quantification. So here's the HMG, and here's erythrocytes with pits, and you can see that there's a good correlation. So this is a nice test that could be introduced to help us diagnose hyposplenism. So let's think about vaccination. What exactly is the problem here? And the problems are twofold, really. The failure to give the patients the vaccines that they need at the start, and then failure to follow them up and give booster doses as indicated over time. And it's worth pointing out that there's a waning of immunity if you use polysaccharide vaccines compared with conjugate vaccines, which are much more immunogenic. And Bianchi et al. Did a review, a meta-analysis over a 10-year period, including 24 studies, to see what the vaccination coverage was. And you can see here it was not very good. Only 13% were vaccinated against meningitis B. Half only had their pneumococcal vaccination. Similar for Hib, a bit less for meningitis C or A, and about half for influenza vaccines. So we need to improve on that. And they showed or found by their study there that if an intra-hospital protocol had been introduced for vaccination with cooperation between surgeon, vaccinologists, and general practitioner, you could increase the vaccination coverage by up to 10-fold. So education and giving people information is really very important. So we can consider why people are not fully vaccinated. And there are 3 reasons that I could come up with, really. The first is, whose responsibility is it? And the surgeon may say, oh, it's the hematologist's responsibility. Oh, it's the general practitioner's responsibility. And so the patient may not get vaccinated, or if they've had an emergency splenectomy, for example, they may get their first vaccination, but then not get the follow-up ones, not the booster doses, not even the full course. And then there are different priorities. The patients who've had emergency splenectomy may be just glad to have survived whatever it was that causes their problem. Or patients with cancer, well, immunization may not be their first priority, and in any case, it may not be wise to vaccinate somebody who's on immune suppressive treatment. And then loss to follow-up, failure of full course for some of the reasons that I've said. But the other thing that we found, certainly in our own families with hereditary spherocytosis, the patients are often not at all aware of the risks. So, for example, when I was working in pediatrics, I would see children with hereditary spherocytosis. This is a condition that's dominantly inherited. So I knew there would be other family relatives, at least one parent. And it was quite common to find that the parent or the aunts and so on had no idea that they were at risk of overwhelming sepsis, and a lot of them had not ever been vaccinated. So there was work to do there. A word about splenic embolization, because that's now being used much more frequently rather than splenectomy after splenic injury. And this is an attempt to preserve splenic function. And the question we might ask is, do these patients require vaccinations? And there's a paper from the United States by Freeman et al. Providing us with a management guideline. And they did a systematic review and meta-analysis of 9 studies. And in there, 240 had embolization compared with 443 control. And they also looked at 3,974 splenectomized patients compared with 686 who'd had embolization. And what they observed was that embolization patients had fewer infection complications and a greater preservation of splenic function. So the top that I've said, they also showed that splenectomy patients had a significantly poorer response to vaccinations when compared to embolization. Several studies that they looked at had found no difference between embolization and normal controls in terms of immune function. And so they conditionally recommended against routine post-splenectomy vaccination in adult trauma patients who've undergone angioembolization for splenic injury. I compared that with what's available in the information in Spleen Australia. I'll come back to that in a minute, where their approach would be to vaccinate the patients who've had splenic embolization with the usual three, that's pneumococcal vaccine, meningococcal and Haemophilus B, and influenza, and then afterwards to make some attempt to find out whether the patient is hyposplenic or not, and then decide whether or not they need follow-up or booster doses. So that's quite useful, really. Test one is to assess for hyposplenic changes, including Hal-Jolly bodies. And then if they don't detect them, the patient's considered to have no evidence of hyposplenism. If they are detected, then they do have hyposplenism. So that's a slightly more cautious approach, but seems to me to be entirely logical. So I've mentioned education. This is really, really, really important, and it's everybody's responsibility. All medical staff, patients and their family, and the material that patients receive should be both verbal and written and electronic where relevant. Improved knowledge reduces the risk of sepsis, and there are a couple of studies that we can look at that show that. First of all, the German study, where education of patients and family practitioners by telephone about vaccinations, an alert card, and a standby antibiotic. They looked at 106 patients with asplenia compared with 113 historical controls and showed significant improvement in education at 6 months. Interestingly, the physician participation was only marginally beneficial. So it's really very important about educating the patients and the primary care physicians. The second one was a Canadian pilot study where an educational booklet and medical alert card were definitely associated with increased vaccination uptake and appropriate fever management. So it's quite clear that we have to do something very positive to educate our patients and their primary care physicians. In the UK, we've got a national health leaflet, which is shown here, which you can find by looking at the appropriate website. So this is a two-sided leaflet. That's the front side, and this is the back side. Obviously, I won't attempt to read it, but this is fine if patients can read, and this is quite a lot of detail. And it does include, for example, get treatment urgently for any bites, such as animal bites or insect bites. And in the UK, we're having an increasing problem, by the way, with tick bites, which is not something I grew up with, as it were. And we have to give our patients good advice about traveling abroad, particularly to malaria areas, and so on. Again, that'll be a risk that you're familiar with. And some patients will be recommended to take antibiotic prophylaxis, but certainly they should have a supply of emergency antibiotics to take if they get febrile. Contact your doctor immediately if you're ill. And these are the three main vaccines, pneumococcal, meningococcal A and B, and I'll come back to that, and why we don't now recommend Haemophilus influenzae vaccine, influenza every year, and COVID-19 vaccine every year. So this is the card that the patient can print out and carry, and they should. But of course, this doesn't work very well either, because often patients don't carry cards, even if they have them, they leave them at home or on top of the fridge or whatever. But this does have the information, and it's important because a lot of medical staff who don't work in the areas that we do will not know about the implications of not having a functioning spleen. They may not know that when they receive a patient into the emergency room who has no spleen and a fever, that this is an emergency, a bit like our patients that have neutropenia. They're subject to sepsis. This allows the patients to tick the vaccines and to write down what their antibiotic that they have as an emergency. What about having a national registry? Well, Australia has been very successful with this, and we'd love to do it in the United Kingdom. And I just put up the population because this is relevant, obviously. Australia is a big country, but it doesn't have a very large population. And where it does have population, they're relatively concentrated in small areas. So the spleen registry was started up in the state of Victoria, but now includes far more. And that's been very useful with a lot of information. And I'll show you some information about that in a minute. But the United Kingdom's 68 million, and obviously the population of India is huge. And I'm not sure how you would set up or run a national registry. Perhaps we can talk about that. So Spleen Australia, take a look at this website after when we finish, because it's really quite impressive. The material that they produce in terms of adults and pediatric guidelines, information from patients, and you can see it started in 2003. And these things always start with somebody who's enthusiastic and somebody who's there to help them. And they've now got more than 13,000 patients registered, and they can put the patients in touch with each other. These are their statistics from May 2024. And I just thought it might be interesting to show you the reasons for hyposplenism. And it's quite interesting to me that most of them were people who had splenectomy or hyposplenism from trauma, then blood disorders, incidental finding, other reasons, and then this group, people with hyposplenism who still have a spleen in. And then this is the page that they have for what you should do if you have a fever on the back of your alert card. And that's quite good, isn't it? It's very pictorial: fever, headaches, can't get warm, diarrhea, vomiting, confusion, exhaustion. And this is to show patients when they should get emergency medical advice and start taking their antibiotics. But there's a lot more information about Spleen Australia on their site. And they provide their hyposplenic patients with a packet that's got written information and the sort of things that the patients need. So what are the essential vaccines that we might consider? And there are 4 groups, really: pneumococcal, against pneumococcal species, Haemophilus influenzae group B, meningococcal species, and then, as I've mentioned, flu, influenza, and COVID-19. The timing should be two weeks before if you're having an elective splenectomy or intervention, or 2 weeks after splenectomy, and as soon as practicable after recognition of non-surgical hyposplenism. But specific scheduling may be required in the context of recovery from immunosuppression. Pneumococcal vaccine, first of all, the important point here is that there are more than 100 serotypes. And the pneumococcal vaccines don't cover by any means all the relevant species. Conjugate vaccines are much more immunogenic than polysaccharide vaccines, but they have a smaller spectrum. So there's PCV13 or PCV15, and we've now got a PCV10 and a PCV20. The 23-valent polysaccharide vaccine provides limited and short-term protection and would require a booster every 5 years. So that's what we could use for adults. This is some data from about the infective pulmonary disease incidence, invasive pneumococcal disease in England, showing how it's diminished with the introduction of pneumococcal vaccines. And that's quite good to show. And then there was a big dip in COVID-19 when we couldn't go out anywhere. And as soon as we were recovering from that, the disease incidence started to go up again. And this is just a list that's, we have a book called The Green Book, which you can find on the web, which is the whole data bank, if you like, for immunization against all the diseases we might imagine. And this book is regularly updated, or should be, to show you what's available in the UK and which vaccines might be indicated. And you can see that these are the serotypes covered by PPV23, the 23. Here's the conjugate vaccine 20, which isn't yet part of our national schedule. PCV 15, 13, and 10. So there are different ones. And it may be important for you to know what the predominant serotypes are in your own area in India, because I don't know how that would affect the vaccines that you use, and you might be able to tell me afterwards. So those two are available, but not part of our national immunization schedules yet. Vaccination against Haemophilus, there are 6 serotypes, but B is the most virulent and accounted for greater than 80% of invasive infections. It was most commonly in children under 5 years of age, and a national vaccination was introduced in the UK in 1992, and children received this now at 8, 12, and 16 weeks of age in a combined vaccine. And then as a routine, Hib Men C on the first birthday. And after that, they don't need any. And now the major change in our recently published guideline was that since Hib disease is very rare in the UK, we don't any longer recommend additional vaccination for hyposplenic patients because of the protection that's given by vaccination in infancy. There are no vaccines for the other serotypes. And this, again, as with pneumococcus, highlights the importance of antibiotic prophylaxis in high-risk hyposplenic patients. They're not all going to be covered, even if they've had a perfect record of vaccination. And this shows the impact of introduction of Hib vaccine right here in about 1992-3. An enormous reduction in the reports of Hib disease, and then there was a bit of a catch-up later on. I thought I'd look and see what countries include Hib vaccines in their vaccination schedules. And you can see that all these blue ones are where it's covered in the entire country. So I see it's recommended in India, as it is in most of Europe. So that's a widespread, very effective vaccine. But if we look at the share of 1-year-olds who received the 3rd dose of Haemophilus influenzae, you can see that the picture's not quite so good. And it looks as if not everybody in India, for example, gets the full protections. But this would be, I guess, between 80 and 90% rather than 100%. So what is recommended is not always completely done. When we consider meningococcal vaccine, there are 12 serotypes, and most of the invasive disease is due to B and C, certainly in our context, maybe serotype A in Africa and India. And it's a nasty disease. It's fatal in 5 to 10%. And even patients who survive can be left with gangrene, which means they lose limbs. They can lose their arms and legs through awful gangrene. And we've seen that most recently, actually, one of our members of parliament who lost all 4 of his limbs through infection with meningococcus in adult life. So Men C vaccination was introduced in 1999, which led to a great reduction in cases of invasive Men C disease. And the teenagers, because the next peak of getting the disease was at university, actually, the late teenage. And so there was a teenage program introduced from 2015, which was very good. And then Men B vaccine was added to routine immunizations in 2015. Conjugate vaccines are very good because they prevent carriage acquisition and they provide indirect protection for the population. So that's been a major advance as well. And you can see here the cases of invasive meningococcal disease by year in England and Wales. And this is from that reference unit I mentioned at the beginning. I didn't quite mention it, but that's where Ray Borrow has been working. Here's where meningococcal C vaccine was introduced. And Men C pretty much disappearing, and Men B disappearing or getting reduced with the introduction of vaccination. And we have, they're called notifiable diseases. If somebody is diagnosed with an infection of any of those 3, Haemophilus, pneumococcus, or meningococcus, it's compulsory to report it centrally. So that's why we have data on the number of infections that we have in the UK. So this complex table is lifted directly from our guidelines. And this chart shows the vaccinations for infants and children up to 10 years of age. So the blue is what they get anyway. And the red is what you would add in addition for people who are hyposplenic. And so it can look rather complicated. Additional Men AC at 1 year, irrespective of the number of doses received before the first birthday. And then at 2 years and 3 to 10 years, you give it if they haven't had it before. And then if asplenia is diagnosed in someone who's never received MenB vaccination, you give 2 doses of this 4 weeks apart. So it is quite complicated, and we were very grateful for Professor Ladani's input into this, and also Ray Borrow. And in adults, 1 dose of this one, ACWY, and if they haven't received MenB vaccination, they get 2 doses of that at least 4 weeks apart. And all adults should receive annual influenza vaccine and COVID-19 according to our national recommendations. And I'm sure yours are similar. Every year we have a new influenza vaccine program and a new COVID-19 vaccine program, which is focused on the people most at risk. This is a summary for children older than 10 years and adults. As I've mentioned, the important point is that Haemophilus influenzae vaccine is no longer recommended. Pneumococcal vaccine, adults and older children will get the PPV23, and then they would need it every 5 years as a repeat because it doesn't maintain its levels. Meningococcal vaccine, they get this one, ACWY, and if they've never received meningitis B vaccine, they get that as well. And then influenza vaccine and COVID-19, as I've mentioned. And then those of us who like to travel, which I do, we would have meningitis ACWY conjugate at least 2 weeks before travel, unless we've had it within the last 12 months. And these are the different meningococcal vaccines that are currently available as listed in our green book. But as I say, it can be quite confusing, which is why we were very grateful for Professor Ladani providing this clear guidance in our guidelines. I found this interesting paper in the Lancet Neurology, which looked at global, regional and national burden of meningitis and its causes for the global burden of disease study. And you can see that in 2019, there was an estimated 236,000 deaths and 2.51 million incident causes of meningitis. The burden was greatest in children younger than 5 years with 11,000 deaths. And it's a good reminder that these diseases are certainly not conquered yet, but substantial progress has been made in reducing meningitis mortality over the past 3 decades. But they notice that more meningitis-related deaths could be prevented by scaling up immunization and expanding access to health services, particularly in lower income countries. And these are the charts. This shows you for 1990. This is meningococcal disease and pneumococcal disease, and you can see how much they reduced between 1990 and 2019, which is very gratifying. And this shows you the age of children. So this is, most of these were in children under 5 years of age. And similarly here, but it's very gratifying to see the reduction. This is also the reduction in Haemophilus influenzae infections. And again, postnatal to 4 years, but very much reduced. And that's a reflection of the introduction of immunization programs. This shows you the, I can't see the top of my screen, so I can't tell you exactly what that is, but the global, amount of meningitis, and you can see that it hasn't been completely eradicated in India. So we need to consider who are the people at particular high risk of overwhelming sepsis. And this is a list of people, and some of whom will need lifelong antibiotic prophylaxis. So first of all, people who've already had a previous episode of invasive pneumococcal disease. Secondly, people treated for hematological malignancy. In other words, they've had splenic irradiation, or they've got ongoing graft versus host disease or ongoing immune suppression. People with thalassemia or sickle cell diseases. And then those of us at extremes of age, less than 5 years, or like me, greater than 60 years, or immediately post-splenectomy and for 1 to 3 years post-splenectomy. So certainly groups 1 to 3 should consider lifelong prophylaxis. How long should antibiotic prophylaxis go on? And these are the recommendations that we now make. All patients following splenectomy for 1 to 3 years. Lifelong only in those at high risk. And there's the potential for development of resistance, side effects, and definitely poor compliance. You know, people don't like taking stuff regularly. They may not understand how important it is. And especially in adolescents, people tend not to stick to the rules that they're supposed to. Then we would consider all asplenic children until 5 years of age to include at least 2 complete years of prophylaxis. And there's some evidence for that from studies on children with sickle cell disease. Which antibiotics should be used? Well, mostly oral penicillin is the antibiotic of choice, used very widely across the world, certainly in areas with low pneumococcal resistance, but you may need to seek microbiological expertise, or you may choose a different antibiotic because of the spectrum of pneumococcal species and their resistance in your own area. So all patients should have rescue antibiotics, appropriate antibiotics for use in an emergency, a packet on the shelf that they start taking if they develop a fever. And then the second important thing is that they absolutely need to understand if they develop some of those signs of infection or symptoms that I showed above, they must go urgently to receive parenteral antibiotics and urgent admission to hospital. And I put the parenteral antibiotics above the urgent admission because it may be quicker for a primary care physician to give a dose of parenteral antibiotics before the patient actually gets to hospital. And we have a major problem with getting people into hospital at the moment. They're overcrowded and a lot of patients end up sitting in a corridor for a while. So give the antibiotics as soon as you suspect a life-threatening infection, just as you would for neutropenic sepsis. And this is important. Antibiotic prophylaxis is absolutely key because current vaccines, as I've shown you, cannot cover all the serotypes of pneumococcus, there are more than 100, or all strains of meningococcus. And so this is a summary, really. Hyposplenism, identify patients at risk, those who've had a splenectomy, those who have diseases associated with hyposplenism, people who've had splenic embolization, increasingly practiced, we might like to discuss that. Then patient education, knowledge of risks of infection and importance of vaccinations. We've got a national leaflet, I don't know whether you have, and then the Australians have got their splenectomy registry, which is excellent. And then sources of information, who should have them? Healthcare providers need to be absolutely educated. And we think that the responsibility must lie with the primary care physicians. That may not be applicable in your setting, but it should be in ours, with clear communication about all vaccinations. And then whether or not the patients have been vaccinated, we should have regular audits of what's happened to patients who've had splenectomy. And we'd love to consider a national registry, but I don't know how in the UK we would set it up. It would need, as described for Australia, an enthusiast to get going. And maybe we could use the National General Practice Database, which Simon de Luzigan helped us with, that's based in Oxford, to at least start collecting data, doing audits. And that may be a foundation for a national registry for us. Vaccinations, as I hope I've indicated, it's essential to use age-appropriate vaccinations according to our schedule, and each country probably has its own schedule. I don't know whether there are regional variations, for example, in India. There have been changes in adult vaccinations recently with the addition of vaccine against meningitis B. No more need for Hib because it's given in infancy, and PCV is now licensed, 20 is now licensed for adults, although it's not yet part of our strategy. Then antibiotic prophylaxis, age-specific, certainly give it to people who are less than 2 years of age or over 65. Cause-specific, we might consider it for certain underlying diseases like sickle cell disease. And we could consider stopping it after 2 years, 2 to 3 years in patients with no underlying disease. And that's a matter of discussion with the patients, because to some extent it's not an absolute decision, it's a voluntary decision. And we absolutely know that people do not necessarily stick to what they're supposed to do, certainly over time. So that's the conclusion of my talk. Thank you very much for your attention, and I apologize for the problems that we had in progressing with the slideshow.
Thank you, ma'am, for a wonderful talk. It was nice learning from you. Thanks a lot. And I now request all our discussants to please put the raise hand sign so that we can start our question answer session with Dr. Pola. Yes, Dr. Satish Kumar.
Thank you, Dr. Paula, for that wonderful session. I had a couple of questions. If a patient has undergone an emergency splenectomy, so we give the pneumococcal vaccine 2 weeks after the splenectomy, say following a accident or some splenic rupture. So you have mentioned to give the polysaccharide 23-valent pneumococcal vaccine. So we have the conjugate Prevnar 13 vaccine. So should we give that and after 2 months give the polysaccharide vaccine, or should we just give one 23-valent polysaccharide vaccine?
Are you talking about an adult?
Adult.
I think you would give the 23-valent vaccine and then give boosters at whatever it was, 5 years.
5 years.
Yeah.
So no need for the conjugate vaccine.
No.
Okay. The other question is, even in India, now Haemophilus influenza vaccine is a part of universal immunization. So
Yes.
do you think we can stop giving it now for splenectomy patients? Because we have been giving it, it's difficult to acquire the vaccine alone. It's a part of the Pentax vaccine. We need to remove that vial and give it. It's quite this thing. So can we just avoid giving Haemophilus influenza B vaccine?
Sorry, did you say it's part of a 5, in infancy, it's part of a whole 5 vaccinations together?
Yeah.
But you would still, when did you start doing that for all infants? Because it's a question of whether it was long enough ago for the population to have the immunity or lack of carriage that we have. And, you know, do you have any idea what the carriage rate is in your enormous population?
Right. So now the coverage is 90%, but I don't know since when it has been started. So if the patient is confident that he has received it, at least I think 3 doses in childhood, I think then we can avoid that, I feel, right?
I think so, yes. And I mean, but it goes to show you, in fact, how important it is to have vaccination records for everybody.
Right.
I think when I'm thinking about our own, my husband and I, as I say, like to travel, you know, I've just had to dig out our previous records because we're about to go to Borneo and we're going to see the health clinic, the travel clinic next week. But, you know, unless people have got a good record of the vaccinations that they've had or their primary care physician has, or they've got a card that says it, I think we haven't been very good about making sure everybody has a record. Are your records good enough to know that?
Not with everyone. Now, I mean, we have software in some hospitals where the records are, you know, the EMR is very good, but in not all places. It's quite a challenge when new patients come in.
I think you mentioned having computer records. I mean, I think with our National Health Service, we now have something called the NHS app that I've got on my phone. And we're definitely all moving in that direction, aren't we? Where our patient records can be in one place and accessible wherever we are. And that's really important because one of the problems we have with transfusion, for example, in patients with sickle cell disease is they develop irregular antibodies to red cells. And then they present to a different hospital with a crisis, and the laboratory doesn't have access to the antibody records unless they've got a national database that they can look at. And there is such a thing actually being developed in the UK. But, you know, when you're looking at a lifetime of a patient, it's very difficult to know all the details. Just as a sort of example, I had my appendix removed in a private hospital when I was 11, which was in 1961, and it's not in my NHS records.
Mm-hmm.
So when I told my GP about it, she said, but I have no record of this. I said, well, I can show you the scar.
Right. Thank you so much.
Thank you, Dr. Satish Kumar. Dr. Chirag Shah, your question, please.
So thank you so much for a wonderful review. Now, you mentioned that after 1 to 3 years, you don't need antibiotic prophylaxis. So is this because there is a kind of the immunity is better now? Are there other organs which take up this immunity and we should not be worried too much about infections after this period?
I think it depends a lot on what the underlying reason is for the hyposplenism or splenectomy. And it's a balance between the risk of overwhelming infection and the compliance, because we know that compliance is not very good, and whether or not the patient's in a relatively high-risk group, as I alluded to. I'm just going to get this up. screen. Let's see what I said. So I think it varies. I mean, it's important to have a discussion with the patient, and with some of them, you need at least 2 to 3 years definite progression. But then I think it's a matter of discussion on how high the risk is in relation to the illness or underlying cause and the sort of environment that the patients are living in. What is their risk of being exposed to those particular bacteria?
But I mean, based on the long-term data of the asplenic patients, does it indicate that the risk is significantly lower on an average after this time period?
I'm not sure that we have data. I think the only data is in patients with sickle cell disease because their risk is ongoing. I'm just looking to see what I wrote about duration. Just getting my slides up on the other side. Yeah, duration.
I ask this because, the compliance of the patients after long term, even for follow-up, is going to be low. And how we can assure them that now your risk is significantly lower.
Well, they have always, I mean, it's like I was saying, they're always at risk because we know that people have presented with overwhelming post-splenectomy sepsis decades after they've had their spleens out. So the need for emergency medical attention and antibiotics on the shelf is absolutely needed lifelong.
Lifelong, okay.
Yeah. But lifelong only in those at highest risk. Otherwise, all patients for 1 to 3 years, and that's a matter of debate. Children until 5 years of age to include at least 2 complete years. So the important thing is the antibiotic prophylaxis and attending the hospital or the doctor if you have a fever. But of course, that's very difficult because people get fevers, don't they? And how do they know whether it's serious enough to make them attend hospital and get some antibiotics? But if you've seen, I'm sure you've seen people with overwhelming meningococcal sepsis. I haven't seen pneumococcal sepsis, but I've certainly seen children and young adults with dreadful meningococcal disease who've lost limbs to gangrene. So you can see how urgent it is to prevent that.
I think perhaps some of it is because we don't keep very good registry, that we don't have a data of this patient. So like in my memory, it's like I have had splenectomies done for the ITP, and they are all doing fine in the absence of my good follow-up, because prospectively now every time they had infection they would not come to us because now they are no longer in follow-up. The ITPs part is well. So when they did infection, who did they go to? And I don't know. It's possible that, yeah.
I think that's a very good point that you raised, because it's the patients who are cured by splenectomy for ITP, and similarly, people who have hereditary spherocytosis, they have a splenectomy and they're no longer anemic, they aren't hemolyzing enough to cause any problems, and they disappear from follow-up and they forget.
Yes.
And that's the people who are at risk. So we have to be very careful in hereditary spherocytosis in who we recommend for splenectomy. And you may or may not know, I'm not a keen enthusiast for splenectomy for ICP, because certainly in children it often resolves without problems, and even in adults the platelet count may be low, but it's not causing problems. And as you've heard, splenectomy may give you problems not only from infection, but in the long term from thrombosis disorders. You need your spleen, and of course the other option for both ITP and hereditary spherocytosis would be partial splenic embolization, where you hope you've retained some immune function but stopped the destruction of the platelets or of the red cells. And I'm quite interested in splenic embolization as a treatment. We looked at partial splenectomy, but that's still quite a major operation. I like the idea of splenic embolization for some of these diseases.
Great. Thank Thank you. Thank you.
Thank you, Dr. Chiraksha. Dr. Nitin Gupta, your question, please.
So thank you, Dr. Paula, and excellent talk. And I think the part of my query has been already raised by Dr. Satish and Dr. Chirag. So I think we do splenectomy very few nowadays, mostly because of in our ITP patients and EIHA, we have better medical treatment options. But yes, I think there are a couple of patients who undergo splenectomy for these cases. And of course, we have other diseases in where we do splenectomy, the traumatic spleen and spherocytosis, yes. So I think in adults, you made it very clear that probably we don't need to give hip vaccine. We need to give only polysaccharide vaccine of pneumococcal, and we don't need to give the Prevnar kind of thing, so conjugate vaccine, and need to repeat vaccine every 5 years, pneumococcal, right? Antibiotic prophylaxis has been quite variable practice among the physicians. So I can say that I do not give antibiotic prophylaxis to my adult patients. And as Dr. Chirag was saying, that we hardly see any overwhelming sepsis in our patients. Of course, they are vaccinated for pneumococcal disease. So of course, I believe the practice is different in pediatric scenario. They need to give some few years of prophylaxis depending upon the diseases you mentioned. So again, it will kind of a targeted question that do you recommend giving antibiotic prophylaxis to our patients, say ITP patients or AIHA patients, of course, if they are fully vaccinated?
I was just looking to see what I said. I think I'm not sure what you would do with an adult, but you'd certainly give them a amoxicillin to keep on the shelf.
Right.
And I'm not sure, I think the risk is highest maybe in the first year. So maybe in an adult, you would do it for a year. Let me just see if we can anything else in the guidelines. I have it in front of me. Because I was mainly dealing with children rather than, let's see. The increased risk of infection in patients with an absence or non-functioning spleen, but is lifelong and highest early after splenectomy. So you probably would give prophylactic antibiotics for a period of time, even in adults. And certainly if they were over 60.
Okay. Need to see kind of review our practice. Then we'll see the data. Thank you.
The American guidelines suggest prophylaxis should be continued for at least an initial 1 to 2 years after splenectomy to cover the initial period of greatest risk. Spleen Australia recommends prophylaxis for a minimum of 3 years post splenectomy. So there you go. It varies with different countries.
Thank you very much. Thank you.
Thank you, Dr. Nitin Gupta. There are some couple of questions from the audience, and Dr. Kannan wants to know that if someone has undergone splenectomy without vaccination, what is the ideal time to start vaccination?
Sorry, I missed that.
If someone has undergone splenectomy without vaccination, what is the usual ideal time to start vaccination in this group?
2 weeks after splenectomy. In other words, as soon as it's reasonable to do it.
Thank you, ma'am. Another question from Dr. Aishwarya Raj. She has a 56 years old patient splenectomized more than 15 years ago. He is a Thel minor with coronary artery disease now and does not give any history of vaccination or antibiotic prophylaxis. Should we vaccinate or give antibiotic prophylaxis now?
I would vaccinate and give information about having emergency antibiotic supply on the shelf, because I think the period of highest risk has passed in terms of getting sepsis, but the vaccinations would still give some protection and be helpful.
Thank you, ma'am. Another question is from Dr. Akanksha. Any role of IVIG in preventing infections in these splenectomized patients?
Not to my knowledge.
Thank you.
Very expensive treatment. And I mean, if you give somebody IVIG, the benefit is only quite short-lived. If you look at the way that we give it for CLL or ITP or whatever, it lasts. The half-life of IgG is quite small, so it's not going to give you protection for more than 2 or 3 or 4 weeks.
Exactly, ma'am. Thank you so much. Another question from Dr. S.K. Sharma. Can we use amoxicillin in place of penicillin?
I would say yes, but that's dependent on the profile of the bacteria around where you're working. But I think people do. I mean, penicillin is the gold standard as it is. But I don't know to what extent there is resistance emerging in different parts of India or the world. And you know, amoxicillin has got a broader spectrum. So I would be inclined for maybe our adult patients to have a supply of amoxicillin because it's got a slightly broader spectrum.
Thank you, ma'am. And any other drug which you can recommend apart from penicillin and amoxicillin?
What do we use for people who are allergic to amoxicillin?
Erythromycin.
Erythromycin, yes.
Thank you, ma'am. Another question from Dr. S.K. Sharma. How about thrombocytosis in splenectomy? And if the patient develops thrombocytosis, do you recommend low-dose aspirin to start in all high-risk patients or all the patients?
I don't, because the presence of high platelet count after splenectomy is normal. It doesn't usually stay up, and it's not, that of itself is not associated with a thrombosis risk. The thrombosis risk is not the platelets, it's to do with other things, maybe to do with the red cells. So I wouldn't advocate using aspirin just because the platelet count's high. And of course, in children, it tends to go higher than it does in adults. They're quite responsive. So no, I wouldn't.
Thank you, ma'am. So I think there are no more questions from the audience. Any other discussion want to ask any other question? So I think, well, there are no, one question has just popped up. Again from Dr. Krishnanatham Kannan. Should we give routine anti-malarial prophylaxis post-splenectomy in an endemic country like us?
Good question. I don't know the answer to that because I don't live in an endemic malaria country. I don't think we've addressed that in our guidelines either. But I mean, we certainly address it for people who are traveling. Let me just check what we've written. I think we've only talked about antibiotic prophylaxis. I don't know what you would recommend in your own setting. Do any of you have views about that? What particular malaria strain do you have in India, or do you have several? And what's the normal?
Most commonly we have P. vivax and P. malaria P. falciparum malaria. So these are the two most common we have. Some of the centers here do also use in patients of sickle cell disease a prophylaxis against P. falci as well as P. vivax, because sickle cell trait patients are more prone for P. falci and the disease are more for P. vivax. So some of the patients of our belt, sickle cell disease, they are using anti-malarial prophylaxis. But I don't know the guidelines do exist or not. I don't know that.
It's a good question, but I just say it's not one we've addressed because it's not a problem that we face. We only face it for people who are traveling, who've got no spleens, who are traveling to malaria areas. And I mean, one of the bits of advice some people give is don't go. Or if we do go, I mean, absolutely take malaria prophylaxis and cover up so you don't get bitten by the mosquitoes. So it is a risk. But I was interested, not to forget the risk from the bugs that dogs and cats carry in their mouths, because that can cause fatal sepsis as well in people with no spleens. And then the parasites that you can pick up from tick bites, mostly reported, I think, in the United States.
No, ma'am. Another question has come from Dr. Shyam. Any risk of pulmonary hypertension with splenectomy? You already mentioned.
There is long-term, and that's quite an interesting finding. And I would recommend you to read the papers that Robert Schilling has produced, because the whole area of that is somewhat controversial. But Robert Schilling had the benefit of working with very large numbers of families with hereditary spherocytosis in the States. So he had a lot of people who'd either been splenectomized or not that he could compare. And then, as I mentioned, they've looked at the, what do they call it? The veterans in the United States, and found that there was a higher incidence of pulmonary hypertension in veterans who'd lost their spleens than in those that hadn't. I'm not sure what you can do about that other than recognize that, there are reasons why you shouldn't do a splenectomy unless you have to, or where you can, as I mentioned, to do a splenic embolization rather than take the spleen out, because you need your spleen.
True. Thank you, ma'am. Another question has just come up regarding in autoimmune disease like SLE, who is having refractory thrombocytopenia with SLE. Is splenectomy advisable, or it has got a very high chance of thrombosis?
I wouldn't do a splenectomy for ITP. And what did you say, lupus?
Lupus.
Yes.
SLE, lupus, systemic lupus erythematosus.
Yes, that's a very nasty disease. And so I would try and manage both the SLE and the ITP with medication, not with splenectomy. I think the splenectomy is less likely to be successful in those patients anyway, with my ITP hat on.
Yes, ma'am. Thank you, ma'am. And another question is, in which subgroup of patients of hereditary stomatocytosis would you recommend splenectomy? Because almost all the patients of hereditary stomatocytosis has got increased chance of thrombosis with splenectomy. Yes. So any thrombocytosis, any hereditary stomatocytosis patients where you would recommend safe for splenectomy?
I don't know enough about it because I'd never seen it, but certainly there's a very high risk of thrombosis. So I guess that the advice would be don't do it. So I'm not sure what your indications for doing it would be. I don't know how severe it gets, whether those patients become transfusion dependent, for example. But certainly it's important to make the right diagnosis, because it's okay to do a splenectomy in hereditary spherocytosis, but not in stomatocytosis. So people need to be clear about which hemolytic disease they're dealing with. And that hasn't always been the case.
Thank you, ma'am. And another similar question which has just come up regarding case of splenectomy for patients of pyruvate kinase deficiency. Do they require additional prophylaxis with antibiotic, or with antibiotic prophylaxis, or has got any increased risk of thrombosis?
Not to my knowledge. I think that's more straightforward. They get benefit from having their spleens out, and you would treat them in the same way that you would anybody else having a splenectomy, as far as I know.
Thank you, ma'am. So that was the last question. And any other discussion? Want to ask any other question? Well, so ma'am, thank you so much. There are no more raising signs and no more questions in the chat box even. Well,
Okay,
thank you so much for a wonderful lecture and wonderful discussion. And
I have a question. Did you make a recording of my talk, and do you make it available to participants afterwards?
Yes, ma'am.
Okay, so they'll be able to pick up some of those references and look at them if they want to. Good.
Yes, ma'am. Thank you. Thanks a lot. And I thank all our discussants for participating in this webinar today. And I hand over to Mr. Sumit Kumar Madan for the final vote of thanks.
Am I audible, sir?
Yes, you are audible. Please go ahead.
Thank you, Dr. Paula Bolton Max, for sparing your valuable time. It was a wonderful presentation, and this presentation and your session was followed by a very, very engaging discussion. On behalf of Zydus, I thank Mumbai Hematology Group, Dr. M.B. Agarwal, for providing us this wonderful opportunity and making us a part of this esteemed academic discussion. I also thank our chief guest for the day, Dr. Vijay Tilak, all the discussants and participants who have joined us for this webinar. Special thanks to Dr. Amit Khurana for navigating this entire program in a highly proficient manner. Last but not the least, this series of webinars is possible only because of continuous support from Perfect Square team. Thank you so much, everybody, and have a wonderful Sunday.
Thank you
so much. Thank you, ma'am. Wonderful talk, wonderful lecture, wonderful discussion. Thanks a lot.
Thank you very much.
Thank you.